Hi everyone, welcome to today's presentation of HCCs, their impact on the coding process. Today we are very excited to have Joy Ewing with us. Joy is an RHIA and a CCS, and she's an approved AHIMA ICD-10 trainer. She has her own company, Joy King Consulting, and she helps us out here at TruCode all the time, and we love her, and we're so excited that she was able to give this presentation today. A couple of housekeeping items here. Basically, remember that you do have that on the right side of the screen. You have the panel that controls where you ask questions and those kinds of things. If it's in your way, just go up to the very top of that where there is the little orange box with the arrow in it and just click on that, and that will move it out of your way. If you want to ask a question, just click to open it up again, go down to where it says questions and click open to that, and where it says enter a question for staff, then that is where you will put your questions, and we will take those questions at the very end. Also, if you'll look down to the very bottom part of your panel on the right, it's got underneath questions, it's got handouts, and that's where your handouts are. Again, right under the question button, there's a handout button. You can click on that, and that's where you can get the handouts for today. At the end of our presentation, we'll talk to you more about how you can get your CE credits for today. So I know we've got a lot of people on, and we've got a lot that Joy wants to tell you today, so I'm going to go ahead and let her get started. Joy, it's all you. Thanks so much.
Thanks, Karen, and welcome everyone. I'm really happy to be able to talk to you a little bit today about HCCs, which does stand for Hierarchical Condition Categories. It's kind of difficult to say that word, but I just wanted to start out with this kind of a beginning slide to just show a broad view of the evolution of healthcare reimbursement. For most of my career, and probably for those of you that have been out there a while, everything was based on the volume, how many patients you saw, you got paid per patient. And now we're into the pay for reporting. We're moving from the pay for reporting, where we started reporting on quality measures, to actually getting paid based on value. And as you can work your way across this slide here, you can see that we're in the category 2, and in some cases the category 3 payment system, where everything is based on value and quality, not just getting paid for treating a body. And because of that, there's a lot going on in healthcare related to how to measure quality, and that gets into the risk adjustment that we're going to be talking about today as a part of HCCs. So the goal for HHS was to have 90% of Medicare reimbursement tied to quality by 2018. I tried to find out exactly where we were on that goal as of right now, and wasn't able to really find whether we've made it up to 90% or not. They did supersede the 2016 goal, so I imagine we're pretty close to that 90% if we're not already there. The claims-based outcome measures and the associated risk adjustment that are greatly impacted by physician documentation and code assignment. So that still plays a huge role, in some cases almost a bigger role almost than the MSDRG reimbursement, but at least the same scale of weight in terms of making sure that everyone is getting paid accurately. The risk-adjusted value-based payment initiatives that are in place right now include the Hospital-Acquired Condition Reduction Program, which covers 5 AHRQ risk-adjusted quality measures, and also an adaptation of 10 safety indicators from the PSI indicators as a weighted composite score of those. Also a part of that hospital value-based reimbursement is the Hospital Readmission Reduction Program. As you are, I'm sure, aware, they've been trying to reduce readmissions for heart failure, AMI, and pneumonia for a few years now, and you need to be aware of the fact that the next diagnoses that are coming down the pike along this area are COPD, elective total hip and knee replacements, and CABG. So those are slated to go into this readmission reduction program at some point in the fairly near future. They also are doing 30-day mortality measures for heart failure, AMI, and pneumonia. And again, they have plans to expand the mortality measures as well for these additional diagnoses of COPD, the elective total hips and knees, and CABG, as I said. And then HCC is kind of a new player on the scene, so to speak, where they are doing risk adjustment for efficiency measures as well. So what is risk adjustment? It allows for differences among patients, taking into account the illnesses that they have, the demographic situation, or the socioeconomic situation that they have that can affect their health care. And it helps to level the playing field so that when you're comparing provider to provider, you can make sure that a provider that treats more sick patients gets equal weight for that compared to a provider that has less sick patients, because obviously their outcomes and their costs, et cetera, are going to be greater for patients that have more severe illnesses. It assesses the effectiveness of the treatment. It evaluates how they're allocating funds for the treatment and whether they're doing them in the most cost-effective manner. And obviously, they're always trying to make sure that they are reducing mortality, readmissions, complications, and cost. Some of the variables, the diagnosis variables that are examples for you to see that affect risk adjustment are on this slide here. A lot of them, of course, are chronic conditions, but there are also some status conditions that play a role here. Obviously, renal failure, metastatic cancer, malnutrition, dementia, liver disease, and you can just see the list. Why is risk adjustment important? Number one, it's being more and more used by all payers, not just CMS, but also the private payers are getting in on the bandwagon with this as well, and it's not going anywhere. In particular, Medicare Part C, which is the Medicare Advantage plans, is being paid based on risk adjustment with HCCs, which is what we're going to be focusing on today. There's also doing risk adjustment related to that quality measure of Medicare spending per beneficiary. And there's also a physician value-based purchasing modifier that's been in play for a while. Risk adjustment plays a role in the accountable care organizations that are out there, and a program that I don't know a whole lot about, but it's called PACE, which is a program of all-inclusive care for the elderly. And it also plays a role in the long-term acute care readmission prediction models that have been developed over the last 3 to 4 years. Risk adjustment factors in severe chronic illnesses that help explain, as I said earlier, higher costs for caring for these patients. HCCs are in particular used for risk adjustment for managed care programs, and that basically helps them to account for changes in the severity of their patient population and their case mix index over time. And it accurately sets performance. I'm sorry, I keep getting this little pop-up button about there's no more attendees that can sign up. It accurately.
Joy, I'm sorry. Joy, sorry to interrupt you. You can make that go away permanently. There's a little box you can check.
Okay. It accurately sets performance targets for quality and efficiency. Don't show again. Is that what I need to check?
Yes. Sorry to interrupt. Yep.
Okay. And as I mentioned, Medicare Part C, as of 2017, there were 33% of Medicare beneficiaries, which is about 19 million people, that are participating in Medicare Advantage programs. And I'm sure that that number is going to continue to rise. And we also have a set of HCCs related to prescription drugs, which relates to Medicare Part D. So what are HCCs? They are diagnostic categories, not unlike the DRGs that we've been dealing with for many years. They are based on demographics and ICD-10-CM diagnosis codes. PCS, CPT, and HCPCS codes do not play any role in these HCCs at all, which is unlike the MS-DRGs. They do provide quality of care comparisons. They are more predictive of readmissions and future costs than the MS-DRGs, which is why they are using them with these Medicare Advantage plans and why they're using them for risk adjustment. There are about 9,500 plus I-10 codes that map to an HCC. In some cases, they might map to more than one HCC, and they include both acute and chronic conditions. They, like the DRG system, they are grouping patients that are clinically similar, that have a similar cost pattern, so that they can, again, sort of level the playing field and make sure they're comparing apples to apples. Currently, there are 79 HCCs being used by CMS, and each one of them has a risk value or a weight, very much like the DRG relative weight. However, they change every year, more so than the MSDRGs. The MSDRG relative weights change yearly in some cases as well, but they definitely do in the HCC world. As I said, that stands for Hierarchical Condition Category, and we're going to talk in a minute about why that word hierarchy is there. They basically are going to adjust payment for these members of the Medicare Advantage plans so that there's higher reimbursement for sicker patients. And the main purpose is to assist in helping the beneficiaries be healthier by addressing chronic conditions before they become really major issues. There are 3 types of HCCs out there. The one we're talking about today is the CMS HCCs for Medicare Part C, but HHS also has a set of HCCs that are being used for non-Medicare patients. And as I said, there's also a set related to prescription drug benefits that adjust risk due to the prescription burden of disease. If a patient has a lot of chronic conditions that require a lot of prescription drugs, they are giving credit for that and factoring that into the risk adjustment. The model, the CMS HCC model for Medicare, basically uses the patient's last 12-month diagnostic coding history to predict future financial utilization and risk for the next year. They're only counting diagnoses from inpatient and outpatient hospital data and physician data, which means that they are not counting, they're not counting data from SNFs, nursing homes, ambulance, DME, or ambulatory surgery centers. Basically, they set a base payment rate for each member in the Medicare Advantage plan based on their HCC risk factor and cost for multiple chronic diseases. And that's where that hierarchy kind of comes into play, because they get credit much more so than in the MSDRG arena for multiple chronic diseases. If they have disease interactions also, like let's say congestive heart failure with renal disease or something that might interact with each other, they apply an adjustment for that to evaluate and set up a hierarchy of what is more severe and what is less severe in those conditions that coexist together. They also have an adjustment for demographics that include age, sex, the original Medicare entitlement, any disability, and their Medicaid status. The guidelines that really guide the way that the CMS HCC model works are in that Risk Adjustment Participants Guide. There's one, the original one came out in 2008, and an updated one came out in 2013. Characteristics of the HCCs include you can assign more than one HCC per encounter, and they are additive, meaning that if the patient has, 5 or 6 diseases that all, and the codes all map to an HCC, then the relative weights in many cases add together to add up to their total risk score. And that's something that we don't really get credit for with the MSDRGs, because you basically get credit for one MCC or one CC, and that's it. So it's important to recognize that those are adding together to come up with that patient's score. So it's important that you capture every HCC diagnosis that applies every single year. And that's the thing that we have to be aware of with HCCs that's different than the MSDRG system in that they are, looking at back for 12 months and they're recalculating a new score for each upcoming year. And so if you had something documented last year that counts, like this status post-amputation that's listed here, it has to continue to be documented in the upcoming year in order for you to get credit for that in the patient's risk factor score. So that's something that we're all going to have to kind of get used to. The diabetes mellitus is one of the diagnoses that does map to HCCs, but it totally depends on the type of manifestations or conditions that are documented with that diabetes and whether it's type 1 or type 2, etc. They're going to, again, group to a sort of a hierarchy of HCCs with unspecified diagnoses or less severe complications, mapping to HCCs that have less risk adjustment factor, and the more severe complications are going to map to HCCs that have a higher weighted HCC. So it's important, again, where that specificity comes in to make sure that it's captured as well as possible, and not only in the documentation but in the codes that are assigned. No sequencing is involved in HCC assignment, and procedures, as I mentioned earlier, are not included. There are a lot of healthcare settings that are included in this process. They take documentation from a broader group of provider types than they do for the MSDRG world. That can include physical therapy, STOT, social workers, certified wound care nurses, nurse practitioners, PAs, and CRNAs, etc. And facilities may, in some cases, receive bonuses for coding for HCCs. So it's important that you find out whether you have contracts that are paying based on HCCs, and be aware of trying to layer coding for those on top of coding for DRGs. Most hospitals and physician offices are getting paid on multiple methodologies without even realizing it. And often the last person to realize it is the coder. And the coder is the one that does need to be aware of that, because they do need to understand all of the different types of diagnoses that they need to be looking for. So the risk adjustment factor is that score, basically, that the patient is assigned for a calendar year. And whatever the risk adjustment factor is for this year, that's going to impact the payment for that member for 2019. And it is, as I said, providing information on the expected healthcare costs for that particular patient. I also talked about the fact that each HCC has that relative weight or risk adjustment factor weight, like a relative weight for a DRG. And they range from the bottom HCCs being 0.118 up to 2.4888. And of course, there's a significant difference in payment for those ranges right there. The diagnosis code does drive the RAF score, and the total score is what drives the reimbursement for that member. If you have inadequate documentation, it's going to take away dollars, just like it does in the MSDRG world, because many unspecified codes do not map to HCCs. This example here on the slide is bronchitis not otherwise specified, not an HCC code. If the doctor doesn't give you some kind of specificity like chronic, simple, chronic, or acute, or whatever, you're not going to get credit for that bronchitis, because only the specific codes are going to map to an HCC. And you can see in this case that if the doctor specified simple chronic bronchitis, the HCC weight is 0.328. So obviously, a lower total RAF equals a healthier member. They're using the value of 1 to sort of represent an average patient. So people that have a risk adjustment factor less than 1 are expected to use fewer resources in that Advantage plan, and obviously those with a higher score of 1, higher than 1, are expected to use greater resources. The sum of the HCC weights for each member added to the age and sex demographic and eligibility adjustment factor is what determines the score for that member. And when you add all that together, you get sort of the average RAF score for the total organization, the total Medicare Advantage plan. Again, similar to the case mix index for a particular hospital. If you have 2 different diagnosis codes, like in the diabetic world, for example, they're going to go with the one that has the highest weighted HCC. So if I have maybe diabetes with a lesser complication coded, documented and coded, and then I have one with a more complex complication documented and coded, the higher one that the one that maps to the higher weighted HCC is going to trump the other one, and that's the one that's going to count as a part of the RAF score. And I already talked about the fact that there are clinically related conditions that may involve an interaction adjustment factor. So the first thing that happens when you're calculating a risk score is coming up with that demographic adjustment. They're looking at the age and sex of the patient, the eligibility status, and this kind of gives you some specificity about what that involves, whether they're dual eligible for Medicare, Medicaid, whether they have any disabilities in addition to just being 65 and over, etc. Are they in a PACE program or a renal dialysis program? Do they live in a community, or do they live in an institution? All of that plays a role in calculating that risk factor for the demographic adjustment. The second thing is looking at their chronic disease burden And that's, again, looking at all the I-10 diagnosis codes that were assigned for that patient for that year. Looking at disease hierarchies, again, that relates to the severity and specificity of the different diseases. And like as I said, if you have two diabetic complications, one has hierarchy precedence over the other if it's more complex. And then the disease interactions. And here on this slide are some examples of interactions that give an adjustment factor. Cancers with other immune disorders, CHF with COPD, CHF with renal disease, COPD with cardiorespiratory failure, or a patient that has an ostomy status and a pressure ulcer. So all of those will give you an adjustment factor for that disease interaction. This is another kind of example of how that disease hierarchy works. This is when you have multiple levels of severity for a particular disease or multiple conditions that are clinically related. And you see the example here where we did have a diabetic, type 2 diabetic with an uncomplicated diagnosis, HCC 19 with a weight of 0.118, but they also were assigned a diabetes 2 code with an acute complication. That went to HCC 17 and the weight was 0.368. So that one takes precedence over the uncomplicated one, and it knocks that one out. And that's where that hierarchy comes into play, because the payment is going to be based only on the most severe and costly manifestation of that disease. In the disease interaction area, again, certain combinations, as I said, can increase the cost, and so they give an extra adjustment factor for that disease interaction. And you can see on this slide that we have diabetes 2, we have CHF, and then we have an interaction adjustment factor for diabetes with CHF, and you get an additional weight added into that risk factor for that patient of 0.182. So in this case, the plan receives payment not only for the risk factors of diabetes and CHF, but for that additional add-on interaction of the interaction between those two diagnoses of the 0.182. Although HCCs do reflect hierarchies among related diseases, if there are unrelated diseases, then the HCCs kind of just all add together, as I mentioned earlier in the presentation. That's, again, why you want to make sure you capture every diagnosis that might map to an HCC as often as it meets the criteria for a reportable diagnosis. And you can see how in this particular case, these are all sort of unrelated conditions, but you have a weight for each one of them, and then you have a cumulative weight as they add together so that your ultimate risk factor score is the 1.301. And this, as I said, is unlike the DRGs, where you don't get credit for a whole lot of those different conditions that affect the severity of that patient's illness. As I said, the scores are calculated on an annual basis. So each January, they start a whole new slate for calculating a risk factor for a patient as a member of the Medicare Advantage plan. And as I said, also, each chronic condition that you want to count as a part of the HCC for that patient has to be reported at least once during that new calendar year in order for it to factor into their score, their new score. It must be coming from a claim for a face-to-face visit with an acceptable provider in an acceptable setting. As I mentioned earlier, inpatient, outpatient, and physician office are the acceptable settings. And if it's not reported in that new calendar year, then it's going to fall off and not carry any weight in that patient's risk factor score. And this is going to be an area that physician education is going to be important to make sure that they understand that. It's also important for you to understand that during a risk adjustment data validation, which is an audit that happens annually by CMS, you can submit up to 5 dates of service to support any one HCC that's coded. So again, anytime you have a diagnosis that meets the reporting requirements as an acceptable diagnosis, it's probably a good idea to make sure it's documented and coded. And the thing that's also important to understand, and I'm going to talk about this a little bit more in a minute, is if the diagnosis is documented clearly and coded correctly, but it falls on a record that is not documented according to the requirements, it can invalidate that encounter and you won't get credit for that. So that's something new and significant with HCCs that we haven't had to worry about before. This is taken from a free calculator at this website at the bottom of the slide. There are some HCC calculators out there, or risk adjustment factor calculators out there that you have to purchase, but this is a free one that you could go online and take a look at. And the first thing that's showing here is that demographic adjustment that I talked about, where you have some, questions that you have to answer. This patient is in a community setting. They're not eligible for Medicaid as well as Medicare. They are on Medicare for age, not because of disability. And they're, they haven't ever had any Medicare for disability. So all of those have to be accurately documented in order to capture that demographic factor. Then the next thing you do is calculate the disease burden. And what I've done here is just go in and add in the I-10 CM diagnosis codes. And as you enter the code and hit enter, it will give you, we're looking at 2018 HCCs, it will give you the HCC, the description of that HCC, and the score for that. That override thing at the next to the last on the right there basically says, is one overriding another? And if you'll look further down, you'll see that I have a BMI code as well as a morbid obesity code, both showing up there. They both go to the same HCC and they both have the same score. One is overriding the other. So they're going to, take the morbid obesity score and not also count it, the BMI score double. So that is going to cancel out the BMI factor there. And then you can see that you just, work your way down and you add in the different diagnosis codes that you have available to you for that encounter. And then it actually calculates it for you. So they are showing me here that based on the questions that I responded to on that first screen about the demographic risk factors, the score for that is 0.694. And then the HCC risk factor for all the different diagnoses that I just entered on the previous screen gives me a cumulative weight of 3.312. And then I'm also getting an interaction factor because of CHF along with diabetes of 0.154. Then I'm getting another interaction adjustment for CHF with COPD of 0.190. And still another interaction adjustment for CHF with a heart arrhythmia of 0.105. So when you add all that together, the total risk factor is 4.006. Then, however, you see that they have this normalized with coding intensity subtraction that they do. They've kind of been doing that in the MSDRG world for a while as well, but they sort of take away a little bit there. I think that the amount that they subtracted there was 0.116 or something to that effect. And I think that they have sort of a factor like that comes out for every single year where they sort of try to back it off a little bit to make sure that you're not getting too much credit for the codes that were assigned. So the total risk factor ultimately for that patient that we just looked at on the previous slide is 3.706. The kinds of conditions that map to HCCs include high-cost conditions like cancer, heart disease, hip fractures. It does include both acute and chronic. It includes a lot of status codes, a lot of etiology and manifestation relationships, COPD, hip fracture, status post-amputation of a great toe, diabetic nephropathy. Again, all of these need to be documented to the highest level of specificity. They need to be recaptured each year in order for them to continue to play a role in the risk factor score for that particular patient. They also include some common conditions, rare conditions, curable conditions, non-curable conditions, and congenital conditions. But just like with the MSDRG world, basically you're supposed to be only capturing diagnoses that meet the MEET criteria. They've been monitored, evaluated, assessed, and treated. Diagnoses that do not map to HCCs, first of all, many of them that are unspecified don't map to HCCs, or diagnoses that don't really predict costs, like appendicitis. If there are diagnoses that have a high degree of discretion or variability in how they're diagnosed, how they're coded, et cetera, how they're treated, they're not going to include those, like a lot of the symptom codes and things like osteoarthritis. And they also do not use codes from lab, radiology, and home health claims, because those are considered to be somewhat unreliable and often indicate rule-out diagnoses rather than confirmed. And only confirmed diagnoses can be used as a part of the calculating the risk score. Again, this is sort of an example of the types of things that you're looking for in the MEET criteria to determine whether this is a legitimate chronic illness or diagnosis to code. Are they monitoring signs and symptoms? Are they looking at disease progression and regression? Are they reviewing test results, looking at medication effectiveness, how the patient's responding to treatment? Are they ordering tests, talking with the patient or the family, reviewing results, counseling? Are they referring to other providers? Are they changing medications? Are they planning surgeries? Are there other procedures, et cetera? And those types of documentation specificities are what you're looking for when you get ready to code. That's a little bit more clear-cut when you're talking about an inpatient setting, but when you're talking about an outpatient setting, and also in particular physician office setting, it's important to really understand what you're looking for in the documentation from the physician in terms of what actually would meet a MEET criteria. And you see at the bottom there a note that says that you only have to have one element of the MEET in order to support that diagnosis. And that's pretty similar to the coding guidelines that we have for coding for DRGs as well. Another example here is just the types of documentation that you might be looking for in the monitoring arena, noting what their blood pressure is, a hemoglobin A1C, what their last lipid panel results were. If they're evaluating, they're going to be noting things like if they have an ostomy or an amputation stump, what it looks like, etc. And then they're going to give adjectives like stable, controlled, worsening, etc. And then treatment, they're going to be changing medications, adding medications, maybe discharging or discontinuing things, referring for tests, etc. This is a slide that sort of gives you an overall view of comprehensive documentation and coding, let's say in the inpatient setting, which is the most comprehensive area that I deal with. You basically want to report all secondary diagnoses that meet the criteria for a reportable diagnosis to the greatest level of specificity. Obviously, you have to focus on MCCs and CCs for MSDRGs. HCCs is something that needs to be layered on top of that, because you don't often know where the diagnoses for a patient's risk factor are going to come from. Sometimes they end up coming from the inpatient setting or the outpatient setting because the physician office records are in such poor shape that they don't meet the medical record completion requirements, and they can't count those. Also, you need to bear in mind that if there are any payers in your state or that your facility is subject to that are paying on APR DRGs, there's risk adjustment in that as well, and that needs to be factored in. Many of the Medicaid, state Medicaid programs have moved or are planning to move to APR DRGs, so you need to be aware of whether that's true in your state, as well as whether there's anyone else in your state that's paying based on APR DRGs. The PSI, the patient safety indicator diagnoses, are also another important thing to pay attention to. Just like we have to worry about the hospital-acquired conditions in the MSDRG realm, the patient safety indicator diagnoses are similar to that, in that you need to make sure before you drop that bill that that patient was or was not going to hit a patient safety indicator. There's a lot of inclusions and exclusions related to those that determine whether they're going to hit a patient safety indicator or not. So you have to pay attention to all of that types of thing as you're coding, and that's a big task for the coders and the CDI people as well, because they have to try to get documentation specificity for all of this. Obviously, the POA indicator plays a huge role. It impacts the hospital-acquired conditions that I just mentioned, and it also impacts many of the PSI indicators as well. So you want to make sure that any POA indicators in the inpatient setting are accurate. You need to pay attention to when surgery was done on that patient. Did they have outpatient surgery and then they got admitted to the hospital setting, because that has a huge impact on what the principal diagnosis is going to be, etc. You need to pay attention to whether the 3-day payment rule for Medicare is being applied for any patient testing that was done prior to the admission. You need to make sure that the admit and discharge dates are accurate, and you wouldn't believe how often I find errors in that arena, especially with patients that come into observation first and then go into the inpatient setting. And the discharge status disposition, also a lot of errors I still see there. That needs to match up with the physician's orders and all the other documentation on the chart. So that's just sort of a comprehensive overview of the types of things that you need to pay attention to make sure that you are capturing everything that's going to impact reimbursement, in particular with an inpatient. Some of the non-specific diagnoses that are really common that can affect, HCCs or risk adjustment or not are listed on this slide. Diabetes without complications, COPD without exacerbation, CHF, if they don't specify whether it's diastolic or systolic, and you have to just assign the I50.9 code, don't get a lot of credit for risk adjustment for any of those types of things. Breast and prostate cancer, hypertensive heart disease, angina, rheumatoid arthritis. Many of these are so nonspecific that they don't map to an HCC, so they don't have any bearing on the risk adjustment for that particular patient. Some of those that are commonly missed that can really impact a risk adjustment are on this slide. Amputation status is a big one. Asthma, ostomies, if they have AAA, abdominal aortic aneurysm, or other areas of atherosclerosis in the aorta. Pathologic fractures of the vertebrae, late effects of CVAs, chronic DVT, depression, alcohol, drug dependence, and renal dialysis status can all play a role. And these are things that coders don't necessarily remember to pick up routinely, but they can play a huge role in risk adjustment, especially for HCCs and also in many cases APR-DRGs. There are a lot of HCC codes that are not MCCs and CCs. So again, if I haven't already given this message before, people that are coding just for CCs and MCCs are missing out on a lot of potential reimbursement across the healthcare spectrum. So that is something that no one should be doing. You must pay attention to other diagnoses that affect risk adjustment for HCCs, APR-DRGs, etc., that go beyond the MCCs and CCs. And again, on this slide, you see a lot of them that are going to give you risk adjustment that are not counting anything in the MS-DRG world, like the atherosclerotic ulcer of the leg, AFib, bipolar and personality disorders, cerebral palsy, cirrhosis, alcoholic cirrhosis, COPD, all the complications with diabetes. And there are a lot of Z codes out there, and a couple of those in particular, like long-term insulin use, I think long-term aspirin, long-term anticoagulants, all of those will give you credit on HCC world, and if you're dependent on event. In TruCode, they came out in April with a new addition to the encoder, which is a wonderful addition from my perspective, and they have included the HCCs, the codes that map to HCCs, and in the tabular, this is what it looks like in the encoder. You see out in that box to the right there in the green, the HCC that groups to, and you can see that all those CHF codes group to that same DRG. When you get out to the code grid, the main screen where you're coding all your diagnoses, you can see that they've added that column to the right out there. And you can notice that second diagnosis there, type 2 diabetes with a foot ulcer, actually groups or maps to 2 different HCCs. And again, which one they're going to choose in applying the score is going to have a lot to do with that disease interaction stuff that I talked about, and the hierarchy, which one has a higher weight than the other, etc. But it's good to know that we now have right in front of us as we're coding a way to capture or recognize those codes that map to HCCs and be able to make sure we pay attention to that. If you're coding a Medicare patient, especially in the inpatient world, you can fill up the 25 slots that go into the electronic claim in a heartbeat with history codes. So you want to make sure that in addition to codes that impact the MSDRG assignment, codes that affect risk adjustment are sequenced up in that top 25, even if you have to manually resequence some of that so that it does go on the claim. Some of the risks with HCC coding, I've referred to these a little bit already, but I want to go back into a little bit more detail about this. Most of the documentation for HCCs is coming from the outpatient setting or physician office visits, not from the inpatient setting, because when you're talking about Medicare Advantage plans, that's, you know, a lot of the encounters are outpatient encounters or physician office encounters. But some of the problems or risks with that are some of the physicians directly assign codes without any coding training whatsoever. It may be the physician himself doing it with the EMR, or it may be somebody in his office that has no official coding guidance and doesn't know the coding guidelines or any of that. There's a big risk there in terms of trying to get accurate coding for HCCs and accurate scores for those members of that Medicare Advantage plan. Some also will select codes from a super bill, which is a major issue because they don't keep those updated very frequently, so they're often outdated super bills. Or they might do it from an EMR drop down, and that number one can limit the available options for specificity. Both the super bill and the EMR can really limit that in terms of capturing the most specific code that really describes that patient's condition or complication. Another little risk about choosing a drop down from an EMR, I've heard quite a few horror stories about physicians that just chose the first option and never even read it to see if it was an accurate diagnosis. And I heard a speaker talking about doing an audit on a physician, an OB-GYN physician group, and they had a lot of diagnosis codes submitted for one of their OB doctors that were not OB diagnoses. And the reason is because he was just selecting the first drop down that he saw and never paying any attention to what it actually said. So all of those are risks in terms of doing this accurately. Also, you can't assume diagnosis. You can't look at lab results and, you know, interpret that they have a certain problem. You can't look at a hemoglobin A1C, for example, and decide that they have, you know, uncontrolled diabetes. You can't assume diagnoses based on the fact that they're on medicine for diabetes, or that they're on medicine for hypothyroidism or anticoagulation or anything like that. And you also can't pick up diagnoses or assume them from the orders that the physician documents. So they have to be clearly documented in order to be coded and counted. They, as I said already, need to be documented to the highest level of specificity, because that's going to determine first whether they even map to an HCC, and second whether they map to a higher weighted HCC in terms of that hierarchy. They also need to include documentation of language to show how the patient's responding to what's being done. And I've got here on this slide some additional words very similar to what I showed you on some previous slides. Also be aware of the fact that outpatient pro-fee or physician office reporting expectations are different from inpatient reporting expectations. So if you're coding for HCCs for outpatient setting or physician office setting, make sure you're paying attention to the participant's guide and, you know, what the expectations are. We also have some things in that participant's guide that are a little bit different to worry about. It has to be a diagnosis that's documented in a section that the coder can code from. For example, that participant's guide says that they can't code from a problem list. Hopefully most hospitals aren't doing that anyway, but I don't know about what physician offices might be doing. They can't code from a medical history, past medical history section, can't code from a super bill. So for example, that last bullet there, if the physician documents a chronic condition such as CHF and past medical history, which they routinely do in many cases, and if that's the only place that that's chronic condition that they're still treating and still paying attention to is documented, is in that past medical history, it cannot be coded as a current condition for HCCs to factor into that score. So that's, again, an area for education for the physicians to make sure that they realize that it has to be documented somewhere that shows that it clearly is still a current condition being monitored and treated. Again, I talked about the meet. They have to be supported by the meet, documentation of the meet. They can't be coded from cloned encounters. Every encounter that you code from has to be a standalone encounter, and it cannot be just copied and pasted from a previous encounter. Again, I've already talked about this several times, but the best practice is to code and bill every diagnosis that maps to an HCC or a drug HCC each and every time that it meets the reporting criteria. I already talked about that for those audits, you can submit 5 dates of service to support any one HCC that you code and submit. And again, if the diagnosis is documented and accurately encoded, but it's documented in a record that has a medical record deficiency and doesn't meet the requirements that CMS requires, you can't count it. And I already talked about that earlier. You also want to make sure that you pay attention to any missed opportunities in terms of reimbursement in general. Does your organization have their own Medicare Advantage plan? Do you get incentives from health plans with the Medicare Advantage plan if you improve risk scores? Is your facility part of an accountable care organization? All of these have risk adjustment issues going on with them, and so hospitals are leaving a lot of reimbursement on the table if they don't code for HCCs, if they have some of these organizations involved in their reimbursement that base their reimbursement based on risk adjustment. For the commercial world, does your organization receive incentives from health plans within the commercial HIE, Health Information Exchange, if they improve risk scores? And Medicaid, as I said earlier, you need to know whether you're being paid for any kind of risk adjustment methodology for Medicaid, such as APR-DRGs. In the inpatient setting, you need to pay attention to medical necessity for inpatient versus outpatient services. I put total knee up there because they've, changed that and taken that off the inpatient only list for certain cases. So you need to be paying attention to, did they treat that, do that total knee outpatient or inpatient, and what are the medical necessity issues that are documented there. And just in general, to verify an inpatient admission, you have to have medical necessity clearly documented. You need to make sure that you are optimizing your MSDRG reimbursement, obviously. You want to capture specificity for SOI and ROM for APR-DRGs, and then you want to look at those HCC tables and capture those conditions that we've already talked about. As you can see from this slide, there are 42% of the HCC diagnoses that are not on the MCC or CC list. So that's a huge list of diagnosis codes that are going to be missed if you're not paying attention to what does impact risk adjustment for an HCC. In the outpatient setting, again, you're really paying a lot of attention to medical necessity. Most of the codes for those medical necessity issues and getting ABN signed are coming from the physician office personnel who often don't have a very specific diagnosis to give the hospital or the facility. You need to make sure that you get documentation of all comorbid conditions that that patient has clearly in the record. Again, linking manifestations to their etiology, because that does affect that hierarchy and severity in HCCs. And the last two I've already talked about quite a lot. In the physician office, has to be from a diagnosis from a face-to-face encounter. You have to go beyond the E&M evaluation and management code that was assigned by the physician and the chief complaint. You have to work on those medical record deficiencies. And one of the things you need to be aware of is that the HCC error rate that CMS looks at comes primarily from physician office data. So if you're working in a facility that is purchasing physician office practices, the HIM people need to be involved in assisting the physician offices in proper documentation and coding and record completion to make sure that it's done correctly and that the HCC risk factors are going to be computed accurately. The validation audits that I mentioned earlier are being done annually by CMS. It's called a risk adjustment data validation. There are millions of dollars in improper payments right now going out for these health plans because of mistakes in documentation and coding. Those audits are basically verifying that the diagnosis codes that were submitted to tabulate those risk scores are documented appropriately in the medical record, and they are also hoping to reduce payment errors, and the RACs are getting in on that as well. Interestingly enough, the OIG does some audits along these lines as well, and they have an even higher rate than the RADV audits, which is not good news. And in many cases, what they're doing with these overpayment error rates, like in other arenas, is they're extrapolating those against the whole plan membership, and that can result in millions of dollars payback. An average payback in the HCC audit error rate realm is $20 million or more. So talking about those medical record requirements that I have mentioned a few times here, every page of that document has to have 2 patient identifiers, name, date of birth, medical record number. It's very, very important, and this is especially where a lot of the problems come with the physician office records, where they do not have patient identifiers routinely on every page like they need to. The date of service needs to be complete, including the month, day, and the year, and legible. It has to be a face-to-face encounter with an acceptable type of provider in an acceptable setting that does count in the HCC model for CMS. It does have to have provider signature with the provider's credential and the date signed. And the date signed is another area where there's often things missing that mean that that physician office code doesn't get counted because it wasn't signed correctly. And then the legibility of all of that obviously has to be very important, and make sure that the auditor is able to read what he's writing in order to validate the risk score. The documentation has to be clear, concise, and complete. We've already talked about the treatment and the plan and linking those conditions to the medications that are being used for those diagnoses, and that is still a problem even in the inpatient world, that often the physician doesn't do that very well. Any one of these things can eliminate a diagnosis that might play a role in a risk adjustment factor score. So it's really important that you pay attention to that, and that's why I said as well, if you're buying up physician practices, they need help with making sure that their record completion requirements do meet the requirements for CMS HCCs. And with that, I will see if there are any questions. I think we have a couple of minutes. These are the references that I used to put this information together, and again, I've got the link there for that free risk calculator listed on that page as well. So, Karen, are there any questions?
Yes, there are actually quite a few questions, so we'll go through some of those as we have time. So first off, one of the questions from Brenda was, what about the positioning of the codes when you're putting your codes in order on the UB or on the whatever form for the physician side? Do you have to worry about the correct coding sequences that have to be in like the top 10 diagnosis space, or what can you tell us about that?
In general, for HCCs, no sequencing is required, but when you're submitting, the claim, the 1500 or the, UB, like I don't care. You can probably tell better than I can how many on the 1500, how many diagnoses they were accepted. I know on the inpatient setting, there's 25 that are accepted, and depending on what you're coding, as I said, if you're coding an inpatient, you're going to make sure that you have the MCCs and CCs, and most people's encoders sequence those to the top anyway. And then you're going to make sure that you're paying attention to anything that's an HAC or a PSI or an HCC, just as you can fit them into the top number of codes that are going to go on that claim. Beyond that, the MCCs and CCs obviously have to be sequenced in a certain way to make sure that they affect the DRG, but that's the main thing, is just making sure that whatever number of diagnoses are going to go across on that electronic claim, that the ones that have anything to do with affecting the reimbursement or affecting risk adjustment or PSIs or whatever are going to be in the number that are going to cross over to the claim. Hopefully that made sense.
Yeah, that did. Thanks so much. We had a couple of questions regarding documentation. Documentation, like you said on one slide, that documentation could come from wound care nurses. We've got a couple questions about what about from nurse practitioners who are actually documenting in the skilled nursing facility, and then the patient is going to the doctor's office or they're going to the hospital. You know, what about that documentation? Or even home health care, you know, what about that documentation? How should coders go about finding and making sure they are getting the right information there documented and encoded?
I believe that you can't specifically take diagnoses from the SNF setting or the home health care setting. However, in terms of making sure that that gets translated back into the physician office record or the outpatient record or whatever, you'll have to kind of think about how to do that. And I'll just be quite honest with you that I haven't looked at that particular part of the participant's guide to know, you know, if they have some guidelines there about how to get that home health documentation or the nurse practitioner documentation from the SNF incorporated. Traditionally, if it's not in the physician office record or the outpatient record that you're coding from, and it's from another site of service, you know, previous to, traditionally we don't usually code directly from those. It has to be incorporated into the actual encounter that you are coding.
So part of that needs to be an education to our doctors then to make sure that if there's anything that they're having to evaluate with the MEET guidelines, that they are also documenting it in their documentation, not just thinking we can get it from the facility as they're sending the documentation over.
Yes. And again, that's off the top of my head without looking in detail in the participant's guide.
Okay, good deal. And of course, the coders also have to think about official coding guidelines, which says, you know, you can only use non-physician documentation for things like BMI and wound stage and things like that too. So they can always use the official coding guidelines to help match up that as well, I think.
Yes. Although, you know, when you're talking about a physician office setting, I'm not sure exactly how that plays a role, and again, without looking at the participant's guide. But yeah, the coding guidelines do have to be factored into all of this as well.
Okay. And there's one question about the TruCode HCC indicators that I think I can probably answer, but she asked if the indicators show up for all users as a default, or do they need to be turned on or off? They actually show up for all users, and they're next to the codes, as Joy showed on the screen there. They're in a little box there. You can turn them off at the level of the patient encounter. If you don't want to see them, you can hide them, but they do show up there whenever you're looking up a code for everyone. So they're there for everybody for TruCode. So that kind of makes it helpful there for you to be able to see those indicators. Another question was, what about telehealth or telemedicine and face-to-face requirement, what you're talking about earlier, because those aren't really face-to-face, but you can use some of the codes for face-to-face. Does that count if they're doing it through telehealth or telemedicine?
Again, I don't know. Without looking into that further, I don't know. But off the top of my head, because everything that I read said it had to be a face-to-face encounter, I'm not sure that just documentation from just a telehealth call can be counted. But I wouldn't be able to for sure answer that without looking into it further.
Okay, and I think we've got time just for one more question, and that is, where can you get just a list of all of the HCCs?
I think there is a file out there, but I don't really, and I could probably find out what it is, but I don't have it off the top of my head. But if you Google it, you probably can find it. You can probably just Google, you know, the HCC diagnosis codes for, you know, whatever year you're looking at, and maybe be able to find it that way. But again, I would have to investigate.
Joy, actually, one of our listeners just said they found it on the Medicare.gov site. It's a huge document, but it's got the list there. So thank you, listeners, for telling us that as well. We appreciate that.
Thank you.
Well, I think we're just about out of time, and I know that Sharon wants to talk to us about how to get our CEs and the recording of this document. So thank you, Joy, so much. Sharon?
Thank you both, and thanks everyone for taking the time to join today. Just quickly wanted to let everybody know that an email will be coming out tomorrow morning that will have a link to this recording. It will have instructions for accessing your CEUs. You can download these handouts. If you have any questions, feel free to respond to that email. That will go to me and I can help you out. I also wanted to remind everyone that other webinars are planned. Those are listed on the TruCode website, so make sure you check those out and you can sign up to receive updates on future webinars. And I think that is it. Any outstanding questions that we didn't get to, I will forward those to Joy, and she can respond to them and we can get back to you by email. I think there might have been a handful that we didn't get to, but thank you everybody for taking the time, and we will see you on another webinar soon.
Thank you.